So the neonatal stuff, well, you do swabs and refer to I mean, should you swab an eye? I'm not sure. My view is, and there is this thing that if it's bacterial, it should affect one eye first and then the other. If they both go at the same time, it's probably viral or allergic. I've looked at all the literature on this, and again, it's one of these diagnostic dilemmas. I don't think the kids I give it to are the kids who wake up in the morning and they've got this sort of massive green pus, and mum takes half an hour to get the eyes open.
Yeah, so you give them chloramphenicol.
I give them chloramphenicol. I'm unhappy with it being prescribed at the pharmacy level. So I think that, we're trying to reduce, we need as many barriers as possible to stop antibiotic use. And I don't think that, I love the pharmacists doing the gout. I don't like them doing the conjunctivitis.
Yeah, because we can do the trimethoprim as well.
Yeah. I think that's absolutely fine. Yeah. But I think this, I'm seeing a lot of kids with bilateral who've got viral, pink eye, which, you think was leprosy when you talk to the daycare centres, honestly. Pink eye.
What are your tactics for avoiding that? Because they're very often.
I write a note and say it's been treated.
But as in when they come in going
for the patients, for the parents.
My eye, and you go, well, I think it's viral. What are you offering?
Well, not much you can. So one of my colleagues puts those opti tears into the eyes. Well, it seems a bit. You just sort of have to sit it out, basically. It's going to take a week to get better.
What about if it gets breast milk for the babies?
Yep. Yeah. Well, they're often the blocked tear ducts anyway.
So, but neonatal do swab and refer to. Is that if you think it's
chlamydia or gonococcal?
Oh, right. Yeah. So otherwise,
so that's like an emergency.
Yeah. But otherwise, you do the breast milk.
Yep. I'm pretty cool on. I don't like fusidic acid because I've seen quite a bit of allergy actually, and then they come in with this big eczema around there. I don't know if anyone's seen that. Yeah, and it seems to happen. I've hardly ever seen it used, but I cringe when I do see it used. This is herpes keratitis. The reason for the little green light on the ophthalmoscope is to see this when you put flourescein in an eye, and that's what you'll see. And that needs a referral to an eye clinic because that's a herpes simplex in the eye. And you should never ever put topical steroids in eyes unless you've got access to a slit lamp. I've only ever done it once in my life, and that's when I was 100 miles in the bush in Canada, and this guy had got fiberglass dust in his eye, so I knew why he had this acute reaction. But I would never and have never put topical steroids in somebody's eye, because if you give topical steroids to this person for their conjunctivitis, you'll blind them. Okay, so that's what the little green thing is. Most people don't know what the little green thing is. That's what the green light's for. But often you can just see it anyway. It shows up quite nicely. You won't see it very often. Ciprofloxacin, 2 conditions. Would you go along with that? That's the big
but not normal salmonella, like non-typhi, non-pyrotyphi salmonella. We try not to treat. We let nature take its course. And also there is resistance, particularly most salmonella typhi and paratyphi is coming from overseas. If it's coming from Southeast Asia, it's often resistant. So that's a bit of a problem too. But UTI, and pyelonephritis we actually allow Cipro too, but I think...
Not as a first line though.
Well, no, I think cotrimoxazole or Augmentin,
Because in the US they give it as for traveller's diarrhea, don't they?
Oh, people have done that for years here too, but...
and you shouldn't take doxy for traveller's diarrhea. Again, it's bad use of antibiotics.
Yeah, I don't even know how useful it would be, to be honest.
Loperamide is fine. And travel with a gastroenterologist if you can.
Yeah.
Diverticular disease. Okay, so this is like a new one. No antibiotics in most cases. If you think they've got peritonitis, they actually need to be in hospital because they're probably perforated. But anything less than, if they've just got a bit of bellyache and it's on the left side, don't give antibiotics. The trial evidence says it makes no difference. And I'm part of a group on the North Shore Hospital, and they've done all this data on, and actually it correlates better with, and this is wildly speculating, correlates better with connective tissue disorders. It may be more an inflammatory condition than an infection, which is quite interesting. It correlates with urinary incontinence and a couple of other collagen disorders. This was BPAC suggesting a clear liquid diet for 2 or 3 days in Rhea says. Not NSAIDs or opioids, and I can't remember why. or gastric irritation. And opiates, of course, which is going to slow the bowel down. I'm just writing a gem now on appropriate use of opioids. They suggest this is being considering if it gets worsening or persistent symptoms, but you'd have to be getting persisting symptoms but no peritonitis. The trouble is they go to hospital, they probably will be given, well actually they may not be, they probably will be given antibiotics. The problem is they've had antibiotics for diverticular disease before, they're more likely to get it again. And they're recommending cotrimoxazole and metronidazole for 5 days. Second line would be Augmentin there. Clearly it's easier to give Augmentin than to give 2 prescriptions, but that's what they're recommending now, I guess, to stop this being prescribed. Diarrhea, back to you. So why the blood? What are you going
I think the blood is a marker of severity.
Okay, so campylobacter would be the commonest one for me.
Yeah, I guess, because I guess it's most common, but blood is particularly associated with shigellosis.
Right. I just had, and there's no trial. It's interesting, actually, there's something you could do in your spare time, actually, is a randomised trial. You think how much campylobacter we see in primary care.
Yeah.
So blood in the stools and history of chicken exposure is usually cooked at home rather than... Places like KFC are pretty good, aren't they? Because they're so standardised, those places, and they can't afford to make a mistake. It's usually people at home having a bit of a cook-up and not... So severe illness, travel...
Well, the BPAC guideline recommends travel, but we don't. Because travel in of itself, everyone comes back from other countries with a bit of E. coli diarrhoea, which the kind of E. coli diarrhoea that causes traveller's diarrhoea we don't even detect in the laboratory. So one of the sort of funny things about laboratory tests for poos is that we just test what we can test for. So the tests dictate what we test for rather than what actually is the most common causes or the most, So viruses cause most of the gastroenteritis, and then E. coli's, they're just E. coli's that you're not used to rather than specific E. coli's. And we don't really test for those things. So we test for what is deemed to be public health important, so the notifiable conditions.
So if someone puts on the lab form that recent travel to India, what would you do then?
Oh, well, if you're requesting it because they've got recent travel to India, yes, we do everything. But I guess what I'm saying is, say if someone goes to Fiji for a week and they come back with squiffiness, and they're not particularly unwell, I'm not interested in seeing their poos in the lab, but if they come back from India and they've had 7 days of quite bad diarrhea and some fevers, I think that's a different scenario, because you're starting to think maybe salmonella, paratyphi, typhi, and those sorts of more yucky things. But because it's so individual based as to whether anyone would go to, I would never see a GP with diarrhea.
Oh, I'm always amazed what people will come in with, but people have different thresholds. I think it's all about. Well, it's interesting. The common pathway is their anxiety about their symptoms.
Yes.
And really, if you're an anxious person and you've got back pain, you're going to think you're dying of cancer, so you go and get help. You and I would get back pain, we'd say, oh God, it's just the back pain, we need to rest a bit more, exercise a bit more or something, and do that, wouldn't we?
Wow, that's because I'm so sensible. Sorry.
We get a lot of requests from children at daycare.
Oh.
If they've got diarrhea, the daycare insists they have a...
Oh, yeah. Yeah, it's a So one of the things that's happened in faeces world is that many of the laboratories have changed from culture to these molecular tests, and so we're picking up more. So we're actually probably doing the general public a disservice, because there's things like, we're picking up VTEC, which is a particular kind of E. coli, over doubled the numbers that we're picking up. We don't have any good clinical data as to know whether we're actually, if it's clinically relevant, all these extra tests we're picking up. And then we're ruining people's lives because the kids can't go to daycare and the parents can't go to work, and it actually has a financial impact on families. And it's because this is a classic example, unintended consequences, but also people working in silos. So the lab thought, this would be a great thing to do. And then I sort of belatedly told Public Health what we were doing, and they went, oh my gosh, Arlo, you should have given us 6 months notice, not 6 weeks notice. So I hadn't, and then Public Health didn't really engage in thinking about, well, do we need to change some of our policies? And there's the poor person member of the public down here that's got no clue that this is all what's going on in the background. So to be perfectly honest, if I was a mother and had a child at daycare, I'd be very reluctant to have any stool specimens tested because,
Then also had some couple of Giardia outbreaks.
Yes.
So
Yes, I know. Yes, I know.
so that might come
Yes,
back, right?
yes, yes, I know.
So to get parasites and... right, go on.
I was just saying, daycare are insisting.
Yes, but they are doing that partly because that's the rules that they get from Public Health. And that's all comes from the 1957 Health Act, 1950 something Health Act. So, yeah. But yes, Giardia, so when you do a faeces test, it's a little bit different in different regions because the targets, the tests being used are different, but Giardia and Crypto are in most of the panels. So the Auckland panel was Giardia, Crypto, Yersinia, VTEC, Shigella, Salmonella, and... help me out here,
Campylobacter, yeah.
So you'll get that in all faeces. And then like the Dunedin panel includes C. diff, which is really inappropriate for children. So then we don't report the children ones.
So, but in Auckland you have to put overseas travel, don't you, to get those?
That's to get, in Auckland, to get, proper those are for those funny parasites that we don't have, like, proper parasites like they have in India and Africa. Not just overseas travel, but you've got to say where. Because I did an audit and had a look, and we did millions and millions and millions, never picked up anything. The only patients you pick them up from is people who've come from proper poor countries. Like not going to Fiji on holiday does not, like for staying at a Fijian resort does not give you a parasite. I'm not very good on parasites. I find them very difficult.
So we can...
Yeah,
we can either go to Feces World or Disney World.
Yeah,
I go to Disney World, I think.
So, but the good thing about those molecular tests is you get results faster. So you get a clearance faster, although you might be slightly less likely to get a clearance because they're more sensitive in some cases. And you also get your original test faster as well. Your positive result faster as well. But I think that the kind of people, as we were discussing, that turn up to the GP with diarrhoea, that's the first kind of inequity in health. And then some GPs will be sending things off left, right and centre, and some will say, no, just wait and see how you go.
Well, patients don't really like doing stool samples, do they? So to some extent they're quite relieved. You say, well, look, if you know better in a week or two, then let's start doing it. And I use that as the... Yes. Because they're not... exposed to untreated water, do you have a comment on that?
So that's Crypto and Giardia, and that's probably quite important from a...
New Zealand trend.
Yeah. And also like animals probably too. So the petting zoos in Easter shows, always see a bout of kids with VTEC and stuff after that.
Oh, really?
So with the zoonoses. But I think, tank water, poorly managed tank water, I think it is valid there from a public health perspective.
Okay.
So they treat with blood in the stool, last for more than 7 days, fever, pregnant, immunocompromised, or risk of transmission.
Yeah, people with campylobacter are often pretty sick. I had a colleague and he lost about 2 weeks off work.
Yes.
And I have to say, when I've treated it with erythromycin, people are it's very anecdotal, symptomatically been better fairly quickly, day or two. Yes. And I felt okay about that. So.
And there was a bit of a phase of using Cipro, but ESR did a survey of laboratory campes a few years ago, and the Cipro resistance is quite high. It's about 40%. So erythromycin and azithromycin resistance is lower. So those are stick with the macrolides.
I think that's why PHARMAC have been cautious about encouraging ciprofloxacin. It's been a microbiological view, hasn't it, that the resistance seems to be acquired fairly quickly.
Yeah.
To that. C. diff? We talked about that earlier.
Yeah, we
didn't
did. I don't think we need to go into
Metronidazole, vancomycin. And vancomycin's IV, I think, isn't it? It's not oral.
It's the IV dose, but then you get them to break the vial and tip it down their throat.
Is it true? A friend of mine in Palm Springs got. Actually, it was interesting. He has Crohn's disease. He went to see his GP, and he had a. It's quite interesting because he pays this GP $500 US a year to be a concierge GP. He can phone her up at any time of the day or email her and get a reply within
That's
24
cheap.
hours. Well, he comes in when he said, I've got a little bit of a headache. She said, it's probably a bit of sinus. Have some amoxil. He gets this raging diarrhea, and it's C. diff. And doesn't get better with all the drugs. So he has a poo transplant.
Yeah.
And that works.
Yeah.
But he said, now the problem with the poo transplant was that then he was lactose intolerant for a while
Oh.
afterwards. Is that?
Well, if he got, I don't know, I haven't heard that, but it could be, possibly.
So he had about 6 months out of action because of, he still has the concierge doctor. I said, why don't you fire your doctor?
No,
but he
no,
wasn't
no,
happy
no.
to do that.
Having
relax?
good flora is supposed to give you better neurotransmittery type things. There's a book about the gut. Have you read it? Yeah, so having health, like eating lentils and stuff is supposed to be very good for your mood.
Lentils.
Lentils. Okay, H. pylori.
Oh yeah, I hate H. pylori. Such a complicated area. So I think the things to say about H. pylori are that H. pylori throughout the world is going down, the prevalence is dropping, and it is associated with growing up in less wealthy circumstances, and it's very associated with where you were born and your ethnicity. So when they've done studies in New Zealand born Pākehā have got quite low rates of, and Māori and Pacific, Māori I think have quite decent rates actually, and people from more populous countries that are not as well off, like Southeast Asia, India, have high rates of H. pylori, but overall as sanitation improves throughout the world, those rates are dropping. And I don't understand this, but one of the gastroenterologists I worked with at Middlemore explained to me in great depth one day, but I was not clever enough to understand. But in some people, if you treat it, it can make some other kind of symptoms worse.
I think reflux gets worse
Yes.
after, and they don't understand why.
Yeah, no, he did have an explanation about some different parts of the tummy or something. So in the BPAC guide, there is quite good BPAC guidelines around where you, because I think what happens in primary care, some people in primary care, anyone who's got any hint of anything, they get an H. pylori test, and if it's positive, they get treated. That's not what's recommended, because some people can have H. pylori and not need treatment, and so if there's no red flags, and then you can just give them some Losec and see if they respond, and if they do, then they don't need testing. And then because the problem is you test, and then you've got to treat the jolly thing, and the treatment is really difficult, and resistance is common. And again, unfortunately, the antibiotic resistance again seems to be very ethnicity, where you were born, and ethnicity based, and the same ethnic and countries have been born are related to lots of resistance as well. I think it's jolly difficult.
I mean, one of the small issues is H. pylori is related to a gastric cancer.
Yes.
And I had a Chinese woman, South
Yes.
Chinese, who, high risk of gastric cancer. She got a gastric cancer, and there was some issue about whether she'd had her H. pylori treated properly, 10 years before. So then it wasn't a medico-legal thing, but the husband, when she died, her husband was very twitchy about had she been treated properly back then.
Yeah.
So it's one of those things. Once you test for it, the monkey's on your back, really.
Yeah, and so I think in that BPAC guideline there is quite nice things, and it's not that I don't think that unreasonable following down as to who should be tested and not. But yeah, I think it can be. And then the follow-up test of cure only if they're high risk for cancer, as you say, or if their symptoms come back or don't go away. So not everyone needs. Because that test is quite expensive. I think it's like $60 or $70 or something. It's not a cheap test.
And it has to be a stool test, and they have to be off omeprazole or the PPIs for at least 2 weeks. I think it's a bit of a pain.
Yeah. I think they're allowed ranitidine though.
Right, okay, yeah.
Yeah.